Good evening, everybody, and welcome all of you to the live program number 149 at Orthopedic Principles. Today, our guest of honor is distinguished faculty Professor Dane Wukich from Dallas, Texas. Professor Wukich is a professor and chair of the Department of Orthopedic Surgery at UT Southwestern, where he holds the Charles Kruger Chair in Orthopedic Surgery. He's also the medical director of orthopedic surgery at the UT Southwestern Hospitals. Prof. Wukich spoke on ankle fractures in diabetics, calcaneal fractures, diabetic foot, and neuropathic joint earlier with us. And today, Prof. Wukich will enlighten us on the surgical treatment of ankle and hindfoot neuroarthropathy. Over to you, Prof.
Thank you, Professor Gopalan. So it's my pleasure again to speak on the surgical treatment of ankle and hindfoot Charcot. Last week we went over an overview, so hopefully this will be a little bit more specific. These are my disclosures. Ankle and hindfoot Charcot really is lumped together, in my opinion, because they're so closely related. You have the tibio-talar joint, you have the subtalar joint, the transverse tarsal joint, the talus, and the calcaneus. And it's actually very difficult to distinguish between the ankle and the hindfoot when the talus is involved. So if we look at it, ankle and hindfoot combined, it represents about 20 to 30% of all Charcot. As I mentioned before last week, about 60% is in the midfoot. It's very difficult to brace, as you can see, because of the malleoli, and it has a negative impact on quality of life. And it's very prone to ulceration because of the malleoli. As you can see on the right, you have a very bad varus deformity. That fibula is going to cause significant skin injury. So it's also a multiple plane deformity, and I think that's a key thing to remember. It's in the sagittal plane, it can be a procurvatum or a recurvatum. In the frontal plane, it can be varus or valgus. And then you get axial rotation that can result in a supinated foot or pronated foot or internal or external rotation, however you want to think of it. And this is a good example of a true multiplanar deformity in a patient with a Charcot deformity. It also can result in leg length inequality. And as a result of that, we can get, we can get collapse of the talus from avascular necrosis or neuropathic fracture. And here's an example of an MRI on a person where you can see edema in the talus and the calcaneus and even in the navicular. Looks reasonably good at this point, but without that being recognized, this is exactly what happened to this particular patient where the talus collapsed. And this results in a shortened lower extremity. The indications for surgery for the ankle and hindfoot are non-braceable deformities, which are very common, instability, an impending ulceration, a non-healing ulceration, recurrent ulcerations, or even osteomyelitis. And finally, although it's a small percentage, persons with Charcot can actually have pain that needs to be managed with surgery. The ideal preoperative evaluation certainly includes assessment of the vascular status. And we like to palpate the pulses, and also I recommend non-invasive testing. Ideally, we'd like the hemoglobin A1C to be less than 8%. In an elective operation, that may be realistic, but in somebody who's got an impending operation and an ulceration, we may have to proceed despite poor glycemic control. You want to correct vitamin D deficiency if possible, which is relatively common in the United States. Stop tobacco use. And finally, do a thorough cardiovascular examination so that these patients will tolerate the surgery. Now, when we look at peripheral artery disease in Charcot Neuroarthropathy, we assessed this a few years ago. And we found that the ankle brachial index is often unreliable because of medial artery calcinosis. The prevalence of peripheral artery disease in our study was about 40%. But the good thing about Charcot is ischemia is relatively rare, only 13%, and we define that as a great toe pressure than less than 60. Now, that's in distinction to patients with diabetic foot ulcers, where ischemia is more common. And the need for revascularization in our patients was only 6%. But the important thing is to recognize this preoperatively so you don't intervene on a patient and end up with a wound that falls apart. And I think that's really the key thing for everybody, is to recognize prior to surgery before you place an incision. Now, preoperative planning, I would recommend that you think about angiosomes, because we place incisions all over the ankle, and it's important to understand which part of the skin is supplied by which vessel. The posterior tibial has three end arteries, to include the medial calcaneal, the lateral plantar, and the medial plantar. Very important when you're thinking of the foot, less important when you're thinking about the ankle. The anterior tibial ends in the dorsalis pedis, and the ABI really measures the dorsalis pedis and the posterior tibial pulses. And so this is an example of your anterior tibial angiosome and your posterior tibial angiosome. But I always think about, what about the perineal angiosome? You can see here that in this picture, it's the lateral aspect of the distal leg and the lateral aspect of the hind foot. And quite honestly, as orthopedic surgeons, we spend a lot of our time in this particular angiosome. And how do we assess the perineal? We can't palpate it, and the ABI and toe pressures don't assess it. We can assess the anterior tibial artery, posterior, and we really can't assess the perineal. It's common for incisions and approaches. We make incisions for open reduction, internal fixation of lateral malleolus fractures. We do osteotomies of the calcaneus. And quite honestly, it's a preferred approach in Charcot. So this is one area where I'm always concerned. And quite honestly, I call it the Cinderella of the diabetic foot, because we could have a normal ABI and have wound dehiscences, and it may be because we have perineal artery disease and we really can't assess for it. The only way that I know, if you have a good ultrasonographer, they can do that. And sometimes you need an angiogram to assess for that. When we do surgery, question is, when is the optimal timing? Historically, people say we should delay this until the active phase of Charcot is over. There's really no high-level evidence guiding that. I think a lot of this stems from many years ago when things fell apart for other reasons. And so I recommend early surgery in ankle and hindfoot Charcot, because once they develop a deformity, again, my approach is to be proactive rather than reactive. I would like to get this realigned so they don't develop a wound, an ulcer, osteomyelitis, infection. And so the goals of surgery are really simple. We want to plant a great foot. We want to provide stability. We want the patient to be able to wear a shoe or a brace. And finally, we want to heal wounds, eradicate infections as well. So what do we know about reconstruction? We know that patients with Charcot have higher rates of surgical site infection. And there are two things that I've learned in my experience that we've published in the Journal of Bone and Joint Surgery, that the presence of neuropathy and a hemoglobin A1C increase those rates. We also know that there's higher rates of non-union. And again, neuropathy and metabolic bone disease if we have bone that's not normal. And finally, we have higher rates of hardware failure, which is largely due to neuropathy. And as you can see, I italicized and highlighted neuropathy in all three things, because that's one thing that these all have in common. And it's one thing we really can't do much about to try and remedy. And this is what happens. This is a patient of mine, and you can see that this nail has migrated plantarly, and we have hardware failure. Now, what about the evidence guiding surgical management? If you look at this, we can see that there are no controlled studies in this article that we published in 2009. Everything was based on case reports or retrospective case series, and they were only level 4 and 5 studies. And so the evidence was poor just 11 years ago when we looked at it. We then updated this review in 2016, and we looked at the literature from 2009 through 2016. And what we found that the quality of evidence was improving. And if you look at this, we had in 2009, no level 2 or 3 studies. And now in 2016, we were starting to see some level 2 and level 3 studies. And so the other thing that we noticed is the level 5 studies, the case reports were starting to disappear. So the quality of evidence is improving, but still not where we want it to be. And so how do we improve the quality of evidence for ankle and hindfoot Charcot? Ideally, we need prospective studies. We also need the outcomes of non-surgical series. If we're going to show that surgery is beneficial, we need to show that in comparison to people that treat these non-surgically. We need to look at, this is difficult because Charcot neuropathy is relatively uncommon and very few surgeons have a large enough series to really do a randomized prospective study. And so ideally going forward, we want collaborative, multi-center studies that would be very helpful in guiding our management. Retrospective studies also remain important, but all studies should have a control group. That control group can be diabetic patients in general, or it can be diabetic patients with neuropathy. Now, the surgical approach for Charcot, I think one thing that I've learned is you must be comfortable in all approaches around the foot and ankle. It's similar to a hip surgeon. They've got to know the anterior approach, posterior approach, lateral approach. They need to know osteotomies, etc. So we have lateral approaches, which is a very common approach. You can have a medial approach, you can have an anterior approach to the ankle, and you can have a posterior approach. Soft tissues really guide which approach to use. In some of these patients that we reconstruct, they may have had multiple previous surgical incisions. And so ideally, you'd like to go through an area that hasn't been touched if you can. And so I think going back to the angiome theory, you have to really think about what is supplying the particular area that you want to approach. This is based on your examination. It may be based on vascular consultation, and certainly is based on previous incisions. So when I look at a surgical approach in an ankle like this, I think about my incision. I want to avoid tension when I close my incision. So how do I do that? If I have a valgus deformity like this, I'm going to want to do a medial approach because when I reduce this, the medial side won't be under tension. If I have a varus deformity, I want to go lateral because when I close the incision, it won't be under tension. And as you can see in these particular illustration, I'm going to go medial so that when I reduce that, that is not under tension. So if you're not comfortable with the medial approach and you make this incision laterally, when you reduce this, the lateral incision is going to be under tension and high risk for wound complications. Surgical plan, I think arthrodesis is a treatment of choice for the ankle. I like to prepare the joints. There are some reconstructive surgeons and some trauma surgeons who may not feel that that's necessary, but I do think a good joint preparation, much like when you're doing a fusion of the spine, is important. I use osteotomies to correct the deformity as needed as well. Unlike the midfoot, exostectomy by itself is rarely indicated. And I think the key is with your surgical plan is to restore stability and do a realignment arthrodesis. And this is just an example of an ankle, and you can see that we have a successful ankle fusion in this particular patient through a lateral approach where we harvested the tibia. Osteotomies are usually closing wedge, and the reason is when you reduce them, it'll be on the non-tension side. You can use an opening wedge on the concave side if you want, and you may need a telectomy to do reduction. So again, you want to think about if you shorten it, it's much easier to get bone apposition. Lengthening osteotomy, such as an opening wedge, actually can increase the risk of non-union, just like anywhere else that we do an osteotomy. The maintenance of height, I think, in my opinion, integrity of the talus is important. Some people don't think that. Some fuse the calcaneus to the tibia. I've often used the femoral head allograft. It is associated with a higher complication rate, but it allows me to restore some length and maintain height. And so the major questions that I look at in a Charcot of the ankle and foot are infection and bone quality. If there's no infection and good quality, I can go down one path. If there's osteomyelitis or soft tissue infection or poor bone quality, I might go down another path. And so this is how I look at it. If I have no infection and good bone quality and my talus is adequate, I will use a femoral head allograft. Others who are great in this from the tibia to the calcaneus, and that's perfectly fine. In this case, I would also look at if there's infection present, be it soft tissue or osteomyelitis or bone quality, in which case I might use external fixation, culture-directed antibiotics, and negative wound pressure. How about postoperatively? I think that these patients should be non-weight bearing for 3 months. That doesn't mean that they all will be. We recognize that patients have balance issue and they may not be necessarily compliant with this, but it's not because they're bad patients. I transition to a walking boot or a Charcot restraint orthotic walker, and some patients may require lifelong bracing. I have no hesitation to use an ankle-foot orthosis or a crow in those patients. Some patients may only require extra depth shoes. What are the outcomes? Well, about 40% of patients will have some type of complication, be it a surgical site infection, hardware failure, non-union, or malunion. You can't practice Charcot reconstruction and have low complication rates. If we had this type of complication rate in adult hip reconstruction or sports medicine or spine surgery, we would be out of practice. But this is something that happens in our cases. But ultimately, most of the time, these complications do not result in loss of limb. Limb salvage, as we can see, and that's avoidance of major amputation. Literature rates are about 90%, but that may be high. Due to the selection bias that, we may pick the patients that are basically the lowest risk. But I think if you're going to tackle this type of reconstructive surgery, your limb salvage rates should be on the order of 90% or above. I want to illustrate a couple presentations that illustrate how I proceed with this. This is a gentleman with type 2 diabetes. He had pain and swelling doing some yard work. He complained of warmth, edema, and redness. And he saw his primary care physician. They took x-rays and reassured that everything was fine and there were no broken bones. And he continued to walk on this. And this is his x-rays from his physician's office. And looking at it, he's right. I don't see anything wrong with the bones. But what I do see on this is that clearly there is asymmetry of the ankle joint. He's going into a valgus deformity there, which would make me suspect that at least the deltoid ligament may not be functioning correctly. Unfortunately for him, he was reassured that nothing bad was present and he continued to walk on this. I saw him a year after his symptoms started. He had difficulty with ambulation. He had also had severe triple vessel coronary disease. He had cardiomyopathy. He had peripheral neuropathy, and he was a tobacco user of 55 packs. He had peripheral artery disease. It wasn't bad, but it was something that was concerning to us. But he had a non-plantigrade foot. When he came to me, this is what his foot looked like. And this is a gentleman who started with that x-ray that I showed you. And he ended up with this particular x-ray, as you can see, with a profound valgus deformity, such that he had a pathologic fracture of his distal fibula, as you can see. Now, in this gentleman who had significant coronary disease, had some peripheral artery disease, this is not something that you can brace. So in consultant with our cardiology consults, we got him tuned up. He was deemed too sick to have coronary artery bypass, so they put bare metal stents in him, and we proceeded to reconstruct him. And so intraoperatively, my plan was to do a talectomy to reduce the calcaneus beneath the tibia and reimplant the talus. And as you can see, because he had a severe valgus deformity, I approached this from a medial side so that when I was done with my reconstruction, the medial side would not be under tension. And I was thinking about this before. And again, the talus, and we're going to swing everything around. And the best way for me to do this is to do a talectomy. And this is exactly what I did. This is his picture of his talus on the back table. And I actually reimplanted the talus at that time. I used it as an acute autogenous graft and inserted a short nail and also supplemented that with additional screws, as you can see. And so here he is, preoperatively and postoperatively. Now he has a plantigrade foot. And this is something that he's going to be able to ambulate with and try and help his cardiovascular status. Case number 2 is a young person with a Charcot ankle. He had come to me after previous attempts at a tibio-talar calcaneal fusion with hardware with plates. He had a lateral blade plate at another hospital and had multiple surgery for debridement of infection, removal of hardware, and he had intravenous antibiotics. He presented with a non-healing lateral wound. And so when I saw him, he had normal pulses. He had a fairly large ulceration with a hypergranular base. It did not probe to bone. There was no purulence present. As you might expect, his sensation was absent, and his orthopedic examination demonstrated limited mobility, but no gross instability, and his foot was relatively plantigrade at that point. And so this is what his x-ray looked like. I clearly did not see a talus, but overall it was lined up fairly well in the frontal plane and also in the sagittal plane. So with him, my goal in a guy that had infection like that, a previous infection, was to really keep him stable. And I thought this was braceable if I could get the wound to heal. And so his laboratory analysis showed that his blood count was normal, sedimentation rate was normal, and his C-reactive protein was normal. We also did wound cultures and a bone biopsy, which were negative for infection. So ultimately, the wound healed with negative pressure wound therapy and some bioengineered tissue. I was pleased with that because I felt that this gentleman, in that position that he was, that was consistent with him having long-term limb survival. And I lost him to follow-up for a period of time. And 2 years later, he returned to me. And his deformity had progressed. He now had a fixed angle valgus deformity. He had 6 centimeters of shortening, and his medial malleolus was nearly touching the floor, and his foot was now non-plantigrade. And he had hypertrophic incisions all about his ankle. And this is what his lateral x-ray looked like. And his AP x-ray was looking. Clearly a marked change when I'd last seen him. In retrospect, my decision-making that it was a stable deformity was wrong, but I was just happy that I got his wound healed, and I felt that this was braceable. Clearly, this is something that's going to be a disastrous situation. So what did I think about? This is a guy who had a Charcot with a history of a remote osteomyelitis. He had a severe right ankle valgus deformity. He had severe malalignment. He had a limb length inequality. And the question is, what do I do in this particular setting? And the question I ask myself is, do I do a staged versus an acute reconstruction? Or should I consider a below-knee amputation in this person? Well, I planned for reconstruction, but I did have the discussion with him about an amputation. And what I felt like the best thing to do was use a dynamic external fixator and do a gradual reduction of deformity, gradual lengthening, and a staged tibial with an arthrodesis. And then I ultimately was going to plan to use an intramedullary nail with a femoral head allograft to take up that space that I created with my distraction. So there he was. We used a femoral head ultimately that I'll show you. And this is what we used. We used a dynamic external fixation device, and we slowly distracted this and corrected his deformity and lengthened him. And you can see here that we're getting some length back just in 1 month of distraction. I didn't make any incisions when I did this. And again, this is just looking at it bigger. And now we can see after 6 weeks of distraction, we have his ankle and foot lined up quite well. It's plantigrade again. And we have space. So once I did that, took off his frame, I did a tibial osteotomy, made a nice flat cut. I then inserted a femoral head allograft and inserted a nail through that and realigned him. And this is what it looked like post-operatively. And here he is having a plantigrade foot. There was a small lateral incision that I had to make to put in the screws laterally, and that was the only incision I made. I made it vertically so that it wasn't under any significant tension. So 3 months afterwards, you can see that he's already incorporating and getting healing at the tibial proximal allograft site. I realize this is dead bone. And again, you can see that's looking good, and he's forming a lot of bone. And then 1 year later, you can see that he's actually healed the tibial proximal portion of the allograft. The subtalar parts I find don't heal very well, but this gives stability. And I know that this is dead bone, and this will heal ultimately by creeping substitution. But this is a gentleman who I was able to restore length and restore alignment and ultimately do this in a staged fashion. There are many people who might have chosen to do bone transport on him using an external fixation device, and that is certainly a great option and an alternative as well. So in summary for my treatment, if I have a Charcot ankle or hindfoot with active infection, I'm going to go down the path of external fixation. If there's no infection, I will use internal or external fixation, or sometimes a hybrid of both to achieve what I want to achieve. We looked at our series of intramedullary nails, a consecutive series of 117 that had a minimum of 1 year follow-up. And what we found that the overall complication rate was 45%. But the diabetes group had a higher rate of superficial infections, but the limb salvage rates were high, 96% in patients with diabetes and 94% in patients without diabetes. What I did find when I looked at specifically those patients that had a femoral head allograft, we had 32 of them, and the 65% of them, or 2/3 of them, had a complication. Now the question is, did the allograft cause a complication, or were they such severe deformities that that was why the complication occurred? The bottom line is we found that it increased the risk of a complication by 3 times, but ultimately, to the best of my knowledge, no patient that had a closed wound, never had wounds, resulted in an amputation, but they got complications such as collapse or hardware failure. So in conclusion, I would say that optimize what you can: the hemoglobin A1C, nutrition, and bone health. Use robust hardware, more hardware than you need. Some talented surgeons prefer plates and screws or external fixation, and that's perfectly fine. I think you should do what you do and do what you do well, whatever you have experience it is. So when treating Charcot Neuroarthropathy, my feelings are that you need the kitchen sink and you need all of your hardware in your armamentarium. Keep that in mind. And I want to thank you for allowing me to present this again. Thank you.
Thank you very much, Prof. Excellent presentation as usual. A few questions that have come up. Suppose the plantar fat pad is very small or insufficient. Do you think nails will create a problem?
I think that's a great question. I think it's possible, but when I use the nails, I make sure that the nail is up to the level of the plantar cortex of the calcaneus. But I think that would be an option. And in that case, I think you might have to choose using some type of plate, screw complex, or even an external fixation. I think your soft tissues absolutely dictate how you proceed. But that's a wonderful question. And I think depending upon what you see, how close the plantar cortex of the calcaneus is, that would be a consideration for sure.
Do the nails that you use have an internal compression possible?
The one that I use does have an internal compression device for the ankle. You can use an external for the subtalar, which I don't do. The other thing is I prefer, and again, this is my opinion, I like a little bit of a valgus nail. And the reason is then I can insert it more lateral in the calcaneus. Most nails are straight, and I find that I don't get much fixation of that, only in the sustentaculum tali. But lots of great surgeons have great results using a straight nail. I prefer a nail with a little bit of valgus.
And do you have experience with plates, Prof? I know you like a lot of external fixators.
Do I have experience with plates?
Yes, for these ankles.
I do, and I've used plates a lot. The only problem with a plate in my experience is that if you have a wound dehiscence, you're staring at the hardware. At least if you have a wound dehiscence and you have internal fixation through an IM nail, in general, the nail's inside. And I think that, again, theoretically, in my opinion, you can manage the soft tissue wound a lot better. You're not staring at a plate. But plates are great. And again, I know lots of people who like different types of plates, blade plates, et cetera, and they're great. And again, I think every surgeon should do what they're comfortable with. For me, because I've experience in treating tibia and femur fractures with a nail, I like using a nail, and I use a long nail. The first case I showed you, I used a short nail. In my first series that I reported, I had 40 patients, 0 tibia fractures. In my next one, 17, I had 4 tibia fractures. So I've gone to a longer nail, getting better fixation.
And any other tips to reduce the incidence of stress fractures? One is use a longer nail, isn't it?
Yes, I think that's been my experience, is to use a longer nail and you get past the isthmus. And the second thing is, it's just a principle like we would use in anything else. You bypass any defect by at least 2 diameters of the bone. So if you've had previous screws or that, make sure that you get a nail that's long enough, or if you're going to use a plate, make sure you bypass it by at least 2 diameters of the bone.
Thank you, Prof. Senthil is also in the room. Senthil.
Morning, Dr. Wukich. This is a very good presentation, a lot of complex cases. So when you use allograft and if you have a failure of the allograft, you showed nearly 65% with implant failure. Does it happen with a lot of bone loss, and how do you salvage that situation?
So Senthil, could you repeat that one more time?
So when you use the allograft and you say there is a high failure rate, when they fail, do you have a lot of bone loss, and how do you salvage the situation?
You do have bone loss, and usually the allograft may not fail completely. I've actually had a couple where I've actually redone it, but in that case, then I'll just try and get a fusion from the tibia to the calcaneus. That's not my first choice, but some people do that routinely. I think that you manage it with bone loss, and allograft is a dead bone. It may take years to completely revascularize that through creeping substitution, but I've never had a case where it's failed to the point where I've had to do an amputation because of the allograft. I do think it's reasonable, and I learned this from Dr. Mencken, a tumor surgeon, maybe to keep those patients with allografts on oral antibiotics for a period of time just because it's dead bone. But that's a great point.
So when they fail, do they not cut out through the calcaneus? You still have enough bone stock on the calcaneus to put another nail?
Yeah, what happens is, and I've learned this, that's a great question. What I've learned through my own is, I showed you in that one case where the screws broke in the calcaneus and the nail starting to migrate below the calcaneus. I look at these very closely at 12 weeks. And if I'm not seeing good healing, what I will do is I will go in and through a small incision, I will take out the proximal interlocking screws and dynamize it effectively. In effect, if that nail is going to move, then if you're in the calcaneus, it will move vertically in an upward direction, and it might collapse, but it's going to move up the shaft of the nail towards the tibia. If you can't maintain that tibial locking screws and it fails, those are very good screws. It can only migrate distally. So my threshold for dynamizing these nails is very low nowadays. In fact, I tell the patients at 12 weeks, I probably will take out these proximal screws. And I found that I saw a couple, Senthil, where I was watching the x-ray and I saw my lateral calcaneal screws start to angle plantarly. It hadn't failed yet. That means the nail's starting to migrate. And I've taken out the proximal screws and I've watched the nail actually migrate proximally, and that screw become horizontal again. That's a lesson I learned the hard way.
So these patients need close monitoring.
The rule with these patients are to double the hardware, double the office visits, and double the non-weight bearing time.
That's great. Thank you.
They're my patients for life. I never discharge a Charcot patient from my practice. They're like my.
That's nice. Yeah. No, this is a commendable work. This is, as you said, the complication rate is so high. It does give you like a this is a field where, you know, you need to kind of really love what you're doing. Otherwise you'll be having sleepless nights, you know, so.
And, you know, but it's rewarding though, because patients come to you, I always tell them, if they can't live with the possibility of losing their leg, then they shouldn't have surgery. And I can actually quote my own series and say, this in my experience is what we can do. But you always have to have that discussion with them. You know, I would make the analogy that if you're a surgical oncologist and you only treated pancreas cancer and you thought about your 5-year survival, you would never do that operation because it's not high. But, you know, you make a difference in people. You might give them quality of life. So I think this is not like a hip replacement or an ACL reconstruction or anything like that. You have to expect complications, but the complications should ultimately not impact the ultimate result if you know and you follow algorithms.
Yeah, I agree. You know, especially the kind of x-rays you are showing, a 90% limb salvage in these kind of cases is something really, I would be very happy to live with it, you know.
The other thing I would say is that if you can do this type of surgery and you're comfortable with it, it makes doing all the other surgery that I do, reconstructive, a lot easier. I mean, you know, when you fix an ankle fracture, when you do an osteotomy of calcaneus, all these principles go into reconstructing a Charcot. And I was not exaggerating that you need the kitchen sink and you need your toolbox. It's like doing, I always say that doing a Charcot reconstruction is like doing a 4th time total hip revision or 4th time total knee revision. It's like opening a box of chocolates. You don't know what you're going to find until you get in there.
So how often you do see Charcot ankle and Charcot midfoot at the same time? Do you address them at the same time, or you stage it?
If I saw them in the city, it's not common. I would do the more proximal thing first, because I think now sometimes you can do a pan-talar fusion and you can correct the midfoot with it. But the ankle to me takes priority, because I think proximal deformity, you get that stabilized where you want it. And then the foot, you can actually pronate, supinate, do different things. If you do the foot first, it's like the analogy, you don't want to malalign the foot and have a bad ankle. And the same thing, if you were doing a total knee and a person had a bad foot deformity, I would like to talk to you about doing it. In that case, you would tell me that you would get the foot and ankle lined up before you do your total knee. So I think it's communication, but in the Charcot ankle, I would do the ankle first and then the foot. And if you had somebody with a total knee, I would say to you, the best thing, let's line up the foot, get it lined up, and then you do your total knee. Otherwise, if you line up your total knee based on what an abnormal foot looks like, you could put it malalignment there.
Mm-hmm. That's right. Great. Good. Thank you. Thank you very much, Dr. Wukich. No more questions for me.
Okay, thank you, Prof. Wukich, for this wonderful presentation, and thank you for your kind gesture to come online and teach the students and orthopedic surgeons all over the world. It was lovely listening to you as usual, and we really look forward for the second part of this lecture, which is going to be, I hope so, on surgical treatment of the midfoot. Thank you very much, Prof.
Everybody be safe out there. Take care of yourself.
Thank you very much.
Thank you. Have a good day. Bye-bye.